Hello class, welcome to Chapter 29, Chest Injuries. After students complete this chapter and the related coursework, they will understand how to manage a patient with a chest wound. Students will learn how to recognize life threats associated with these injuries and how to provide immediate intervention. The curriculum includes a detailed description of the anatomy and physiology of the chest and underlying organs, as well as the pathophysiology, complications, assessment, and management of chest injuries. Age-related issues are discussed specific to pediatric and geriatric chest trauma. This chapter also provides information on incidence, morbidity, and mortality, and a detailed discussion of blunt versus penetrating or open trauma. Specific injuries discussed including sucking chest wounds, pneumothorax, tension pneumothorax, hemothorax, Flail Chest, and pericardial tamponade. Introduction. Chest trauma causes more than 700,000 emergency department visits and more than 18,000 deaths in the United States each year. Such injuries can involve the heart, lungs, and the great blood vessels. They may be a result of blunt trauma, penetrating trauma, or both. EMTs must treat any injuries that interfere with the body's mechanism of normal breathing without delay. Internal bleeding can collect in the chest cavity, compressing the lungs or heart. Air may collect in the chest and prevent the lungs from expanding. Anatomy and physiology. Remember the difference between ventilation and oxygenation. Ventilation is the body's ability to move air in and out of the chest and lung tissue. Oxygenation is the process of delivering oxygen to the blood by diffusion from the alveoli following inhalation into the lungs. Injuries affecting the patient's ventilation or oxygenation are serious and may be life-threatening. The chest thoracic cage extends from the lower end of the neck to the diaphragm. A penetrating injury to the chest may also penetrate the lung and diaphragm and injure the liver or stomach. Thoracic skin, muscle, and bones have similarity to skin, muscle, and bones in other regions of the body. Unique features such as the striated or skeletal muscle allow for ventilation. Intercostal muscles extend between the ribs, not yet developed in very young children who tend to breathe from the diaphragm or belly breathing. Innervated from spinal nerves allow the chest to expand on contraction and the active portion of ventilation to occur. The neurovascular bundle is a network of nerves, arteries, and veins lying closely along the inferior of a slightly posterior to the lower margin of each rib. Can be a source of significant bleeding into the pleural space. The pleural covers each of the lungs and the thoracic cavity. The partial pleural is the inner chest wall lining. The visceral pleural covers the lung. The small amount of pleural fluid between the partial and visceral pleural allows the lungs to move freely against the inner chest wall as a person breathes. The ribs are connected in the back to the vertebrae and in front to the sternum. The trachea divides into the left and right main stem bronchi, which supply air to the lungs. The thoracic cage contains the heart and the great vessels, the aorta, the right and left subcutaneous arteries and their branches, the pulmonary arteries, and the superior and inferior vena cava. The mediastinum is the central part of the chest containing the heart, great vessels, epiglottis, and trachea. This location is where the thoracic aortic dissection can occur, a severing of the aorta that can occur when the body is exposed to traumatic forces. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. Mechanics of ventilation. The intercostal muscles between the ribs contract during inhalation. The diaphragm contracts or flattens at the same time. The enterothoracic pressure inside the chest decreases, creating a negative pressure differential. Air then enters the lungs through the nose and mouth. The intercostal muscles and the diaphragm relax during exhalation, allowing air to be exhaled. The body should not have to work to breathe when in a resting state. This illustration on this slide shows the anatomy of the thoracic cavity during inspiration and expiration. A patient whose spinal cord is injured below C5 level may lose the power to move the intercostal muscles. The diaphragm should still contract. The patient will still be able to breathe because the pneumothorax nerves remain intact. Patients with spinal injury at C3 or above can lose the ability to breathe entirely. The minute ventilation or minute volume is the amount of air moved through the lungs in 1 minute. It is calculated by multiplying the normal tidal volume by a patient's respiratory rate. Patients with decreased tidal volume will have an increased respiratory rate. A 1,000 to 1,500 milliliter bag valve mask might overinflate the lungs, causing gastric distension and impaired lung function. Overventilation can increase interthoracic pressure, reducing cardiac output and potentially worsening chest injuries such as a pneumothorax. Additionally, rapid respirations can cause acid-base imbalance and a blood gas imbalance. Injuries of the chest. There are two basic types of chest injuries, open and closed. In closed chest injuries, the skin is not broken. They are generally caused by blunt trauma. They often cause significant contusions in cardiac muscles, cardiac contusion, and lung tissue, pulmonary contusion. If the heart is damaged, it may not be able to refill with blood, or blood may not be pumped with enough force out of the heart. Results in cardiogenic shock. Lung tissue bruising can result in exponential loss of surface area, leads to decreased oxygen and carbon dioxide exchange, can cause hypopneic and hypercarbolic states. Rib fractures can lacerate lung tissues and cause further vessel damage with each chest wall movement. Can rapidly lead to hypovolemic shock. In open chest injuries, an object, such as a knife, bullet, piece of metal, broken end of a rib fracture, penetrates the chest wall itself. Such injuries can cause instant damage, but symptoms develop over time. An impaled object remains in place. Do not attempt to move or remove the object. Maybe occluding the hole in a punctured vessel removing would cause heavy bleeding and may cause damage during removal. Blunt trauma to the chest may fracture the ribs, sternum, and chest wall, bruise the lungs and heart, and even damage the aorta. Almost 1/3 of people killed immediately in car crashes die as a result of traumatic rupture of the aorta. Vital organs can be torn from their attachment in the chest cavity, causing internal life-threatening bleeding. Signs and symptoms of a chest injury. Pain at the site of injury. Pain localized at the site of injury that is aggravated by or increased with breathing. Irritation of or damage to the pleural surfaces causing sharp or sticking pain with each breath. This is called pleuric pain or pleurisy. Bruising to the chest wall. Crepititis with palpitation of the chest. Any penetrating injury to the chest. Dyspnea, difficulty breathing, shortness of breath, can be caused by airway obstruction, damage to the chest wall, improper chest expansion, or lung compression. Prompt vigorous support of oxygenation and ventilation with prompt transport are required. Hemostasis, spitting or coughing up blood, indicates damage to the lung or air passage. Failure of one or both sides of the chest to expand normally with inhalation. Rapid, weak pulse, and low blood pressure. Principal signs of hypovolemic shock can result from extensive bleeding of lacerated structures within the chest cavity. Cyanosis around the lips and fingernails, sign of inadequate respiration. Immediate ventilation and oxygenation are required. Patients with chest injuries often have tachypnea, or rapid respirations, and shallow respirations because it hurts to take a deep breath. The patient may not actually be moving air due to chest wall trauma. Acute multiple lacerations on the chest wall to assess for adequate breath sounds. Patient assessment. Scene size up. Scene safety. Observe for hazards and threats to the safety of the crew, bystanders, and the patient. If the area is a crime scene, do not disturb evidence if possible. Request law enforcement for scenes involving violence, such as assault, gunshot wounds. If needed, call for the electrical utility, fire department, or advanced life support (ALS) units early. At a minimum, use gloves and eye protection. Mechanism of injury. Chest injuries are common in motor vehicle crashes, falls, industrial accidents, and assaults. Determine the number of patients and consider spinal stabilization. Primary assessment. Form a general impression. Life-threatening hemorrhage, when present, should be addressed immediately, even before airway concerns. Note the patient's level of consciousness. Perform a rapid physical examination. Observe injuries, appearance of blood, difficulty breathing, cyanosis, irregular breathing, chest rise and fall on only one side, accessory muscle use, extended or engorged external jugular veins, assess airway, breathing, and circulation, assess overall appearance, and ask, how sick is this patient? Airway and breathing. Address life threats beginning with the airway and breathing unless life-threatening uncontrolled bleeding is seen, ensuring that the patient has a clear and patent airway. Normal breathing should be effortless, and any deviation from this pattern should be cause for concern. Consider early cervical spine stabilization when blunt trauma is present. Note whether the jugular veins are distended. Sign of possible tamponade on the heart. May result from a tension pneumothorax. Also may result from an injury to the heart allowing bleeding into the pericardium. This is a pericardial tamponade. Determine whether breathing is present and adequate. Inspect for decap BTLS. Look for equal expansion of the chest wall. Unequal expansion indicates loss of muscle function. May be due to a direct injury to the chest wall. May be related to an injury of nerves controlling those muscles. Check for paradoxial motion and abnormality associated with multiple fractured ribs. Apply occlusive dressings to all penetrating injuries to the chest. Support ventilations. Apply oxygen via a non-rebreather mask at 15 liters per minute. If breathing is inadequate, provide positive pressure ventilations. Do not use this type of ventilations for patients with a pneumothorax. Continue to auscultate breath sounds and reassess the effectiveness of ventilatory support. Be alert for decreasing oxygen saturation. Can lead to hypoxia. Be alert for signs of impending tension pneumothorax. Increasingly poor compliance during ventilation. Circulation. Assess the pulse and determine whether it is present and adequate. If the pulse is too fast or too slow, or if the pain is pale, cool, or clammy, consider the patient to be in shock. Addressing life-threatening external bleeding immediately. Control external bleeding using direct pressure and a bulky trauma dressing. Transport decision. Priority patients are those who have a problem with their airway, breathing, or circulation. Pay attention to subtle clues. Appearance of the skin, level of consciousness, a sense of impending doom in the patient. A delay on scene to perform a lengthy assessment can reduce the chances of survival for the patient. With chest injuries, when in doubt, transport rapidly to the hospital. Table 29-1 lists the deadly dozen chest injuries. This table on this slide lists the deadly dozen chest injuries. History taking. Investigate the chief complaint. Further investigate the mechanism of injury, the MOI. Identify associated signs and symptoms and pertinent negatives. Verify when the pain is located in relationship to an area being touched. Pertinent negatives when examining the chest. No associated shortness of breath, no rapid breathing, no absent or abnormal breath sounds, no areas of deformities or abnormal movement, equal expansion of the chest and movement of the rib cage and the diaphragm can confirm that there is a nerve conduction to that region of the body. Sample history. A basic evaluation should be completed when time allows, with a focus on signs and symptoms, allergies, medication, pertinent medical problems including respiratory or cardiovascular disease, last oral intake, events leading to the emergency. Questions should focus on the MOI, speed of the vehicle or height of the fall, use of safety equipment, type of weapon used, number of penetrating wounds. Secondary assessment. Physical examinations. For an isolated injury with a limited MOI, focus on isolated injury, patient's complaint, body region affected, ensuring wounds are identified and bleeding controlled, location and extent of injury, assessment of all underlying symptoms, anterior and posterior aspects of the chest wall, changes in the patient's ability to maintain adequate respirations. For significant trauma likely affecting multiple systems, start with a rapid physical examination. Use DCAP BTLS to determine the nature and extent of the thoracic injury. Vital signs. This activity should include assessment of pulse, respirations, blood pressure, skin condition, and pupils. Reevaluate the patient every 5 minutes or less. A rapid pulse or respiratory rate may indicate that the chest injury is causing a decrease in available oxygen, hypoxia, or blood loss resulting in decreased red blood cell count, hyponemia. Increased work of breathing can be identified by the use of accessory muscles in the face and neck and chest. Pulse and respiratory rates may decrease in the later stages of chest injury. The myocardium becomes starved for oxygen and the body can no longer keep up with the demands. The brain becomes starved for oxygen and overloaded with carbon dioxide and other waste products. Reassessment. Repeat the primary assessment, reassess the chief complaint, reevaluate airway, breathing, pulse, perfusion, and bleeding. Interventions. Reassess vital signs and observe trends. Provide appropriate spinal stabilization for patients who have blunt trauma with suspected spinal injuries. Maintain an open airway. Be prepared to suction the patient. Consider an oropharyngeal or nasopharyngeal airway. Control significant visible bleeding. Provide high-flow oxygen. Place an occlusive dressing over penetrating trauma to the chest wall. For patients with signs of hypoperfusion, provide aggressive treatment for shock. Provide rapid transport. Do not delay transport to complete life-saving treatments. These can be performed en route to the hospital. Communication and documentation. Communicate all relevant information to the staff of the receiving hospital. Describe all injuries and treatment given. Complications and management of chest injuries. Pneumothorax, commonly called a collapsed lung, describes the accumulation of air in the pleural space. Air enters through a hole in the chest wall or surface of the lung. The patient's attempts to breathe cause the lung on that side to collapse. Blood passing through the collapsed portion of the lung is not oxygenated. Breath sounds are affected side of the chest indicate different conditions. If the lung is collapsed past 30 to 40%, you may hear diminished breath sounds. Absent breath sounds may indicate a tension pneumothorax. A sucking sound on inhalation and the sound of rushing air on exhalation indicate that the chest wall has been penetrated. The illustration on this slide shows how a pneumothorax occurs. Air leaks into the space between the pleural spaces from an opening in the chest wall or the surface of the lung. Air in the pleural space causes the lung to collapse. An open chest wound is often called an open pneumothorax or sucking chest wound. After clearing and maintaining the patient's airway and then providing oxygen, these wounds must be rapidly sealed with an occlusive dressing. The dressing prevents the air from being sucked into the chest wound. Two types of occlusive dressings are available: commercial vented occlusive dressings, improvised occlusive dressings utilizing petroleum jelly, Vaseline-based gauze, aluminum foil, or plastic. A flutter valve is a one-way valve that allows air to leave the chest cavity but not return. Follow local protocols and manufacturer guidelines. After applying the dressing, carefully monitor the patient for signs of tension pneumothorax. If it develops, open the occlusive dressing on one side. Consult local protocols and manufacturer guidelines. The illustration on this slide shows a sucking chest wound. The air passes from the outside into the pleural space and back out with each breath, creating a sucking sound. Simple pneumothorax does not result in major changes in the patient's cardiac physiology. Commonly the result of blood trauma that results in fractured ribs. Decreased breath sounds associated with significant lung collapse. Signs and symptoms: dyspnea, increasing work of breathing, and increased respiratory rate. Tachypnea, and accessory muscle use. Decreased oxygen saturation, a crackling sensation felt on palpation of the skin. Subcutaneous emphysema. Late findings: decreased breath sounds on the injured side, lethargy, cyanosis. Be vigilant because the simple pneumothorax can often worsen and deteriorate into a tension pneumothorax or develop complications like bleeding or hemothoracic. Pre-hospital treatment: provide high-flow oxygen, monitor the oximeter readings and breath sounds, treat the underlying cause of injury. Do not withhold positive pressure ventilation if the patient needs support. May cause tension pneumothorax. Have a plan to resolve the complications. Tension pneumothorax, resulting from ongoing air accumulation in the pleural space. This air gradually increases the pressure in the chest, causes complete collapse of the unaffected lung. Mediastinum is pushed into the opposite pleural cavity. Blood cannot return through the vena cava to the heart. Decreased cardiac output leads to shock, ultimately results in death. Tension pneumothorax is commonly caused by blunt injury in which a fractured rib lacerates the lung or bronchus. Common signs and symptoms: chest pain, tachycardia, marked respiratory distress, absent or severely decreased lung sounds on the affected side, hypotension, altered mental status, jugular vein distension, JVD, cyanosis, tracheal deviation. Pre-hospital treatment: support ventilations with high-flow oxygen. Request ALS support or transport immediately. Needle decompression may be performed by ALS personnel or emergency department staff depending on local protocols. This illustration on the slide shows a tension pneumothorax. Hemothorax, a condition in which blood collects in the pleural space from bleeding around the rib cage or from a lung or great vessel. The illustration on this slide shows a hemothorax, a hemopneumothorax, and a hemothorax is a collection of blood in the pleural space produced by bleeding within the chest. When both blood and air are present, the condition is called a hemothorax. Common signs and symptoms. Signs and symptoms of shock without any obvious external bleeding or apparent reason for the shock state. Decreased breath sounds on the affected side. Lung is being compressed by the blood. Pre-hospital treatment. Bleeding cannot be controlled in the pre-hospital setting. Provide rapid transport to the nearest facility capable of performing surgery. Pneumothorax, the presence of air and blood in the pleural space. Cardiac tamponade. Cardiac tamponade, or pericardial tamponade, occurs more commonly with penetrating chest trauma, although it may occur with blunt trauma. The protective membrane around the heart, the pericardium, fills with blood or fluid. The heart then cannot pump an adequate amount of blood. This illustration shows cardiac tamponade. With cardiac tamponade, fluid builds up within the pericardial sac, causing compression of the heart's chambers and dramatically impairing its ability to pump blood to the body. Signs and symptoms. Beck's triad. Distended or engorged jugular veins seen on both sides of the trachea. Narrowing pulse pressure. Muffled heart sounds. Altered mental status due to decreased blood flow to the brain. Pre-hospital treatment. Support ventilations. Provide positive pressure ventilations to any patient who is hypoventilating or apneic. Rapidly transport the patient to a facility capable of intervention. Rib fractures. Common particularly in older people whose bones are brittle. A fracture of one of the upper four ribs is a sign of very substantial MOI. A fractured rib may lacerate the surface of the lung, causing a pneumothorax, a tension pneumothorax, a hemothorax, or a hemopneumothorax. Signs and symptoms. Localized tenderness and pain when breathing, rapid shallow respirations. The patient holds the affected portion of the rib cage. Pre-hospital treatment. Supplemental oxygen. Flail chest, caused by compound rib fractures that detach a segment of the chest wall from the rest of the thoracic cavity. The detached portion of the chest wall moves opposite of the normal paradoxial motion, in during exhalation and out during inhalation. Paradoxial motion is a late sign of a flail segment. Pre-hospital treatment. Maintain the airway, provide respiratory support if needed, give supplemental oxygen, perform ongoing assessments for possible pneumothorax or other respiratory complications. Treatment may also include positive pressure ventilations with a bag valve mask. Restricting chest wall movement, splinting of the flail segment with a bulky dressing is no longer recommended. Flail chest may indicate serious internal damage and possible spinal injury. Other chest injuries. Pulmonary contusion should also be suspected if the patient with a flailed chest. The pulmonary alveoli become filled with blood and fluid accumulates in the injured area, leaving the patient hypoxic. Pre-hospital treatment. Provide supplemental oxygen and positive pressure ventilation as needed to ensure adequate oxygenation and ventilation. Other fractures. Sternal fractures require a significant amount of force, create an increased Index of suspicion for injuries and underlying organs, lungs, great vessels, and heart. Clavicle fractures. Covered under skeletal muscle, significant damage or disruption to the large neurovascular bundle the clavicle protects is possible. Suspect upper rib fractures in medial clavicle fractures. Be alert to possible signs of pneumothorax development. Traumatic asphyxiation, characterized by distended neck veins, cyanosis in the face and neck, hemorrhage in the sclera of the eye. Involves sudden, severe compression of the chest, which produces a rapid increase in pressure within the chest. Example, an unrestrained driver who hits the steering wheel. Suggests an underlying injury to the heart and possibly a pulmonary contusion. Pre-hospital treatment. Provide ventilatory support and supplemental oxygen. Monitor vital signs during immediate transport. Blunt myocardial injury. Bruising of the heart muscle. Blunt trauma may injure the heart itself, making it unable to maintain adequate blood pressure. Signs and symptoms: irregular pulse rate, ventricular tachycardia, and ventricular fibrillation are uncommon. Patient may complain of chest pain or discomfort, similar to cardiac symptoms. Suspect myocardial contusion in all cases of severe blunt injury to the chest. Pre-hospital treatment. Monitor the patient's pulse carefully. Note any change in blood pressure. Provide supplemental oxygen and transport immediately. Hemothorax. Blunt chest injury caused by a sudden direct blow to the chest that occurs only during the critical portion of a person's heartbeat. May result in immediate cardiac arrest. This phenomenon has been documented to have occurred after patients were struck with softballs, baseballs, bats, snowballs, fists, and kicks. Resulting ventricular fibrillation responds positively to defibrillation within the first 2 minutes after injury. More commonly associated with sports-related injuries, but should be suspected in all cases in which a person is unconscious and unresponsive after a blow to the chest. Lacerations of the great vessels may be accompanied by massive, rapidly fatal hemorrhage. The great vessels include the superior vena cava, the inferior vena cava, the pulmonary arteries, 4 main pulmonary veins, the aorta and its major branches. Pre-hospital treatment: cardiopulmonary resuscitation, ventilatory support and supplemental oxygen if appropriate, immediate transport. Remain alert for signs and symptoms of shock. Closely monitor changes in the baseline vital signs, tachycardia, and hypotension. Okay, class, let's go over some review questions. Review question 1. When the chest impacts the steering wheel during a motor vehicle crash with rapid deceleration, the resulting injury that kills almost 1/3 of patients, usually within seconds, is A. Hemothorax, B. Aortic shearing, C. A pneumothorax, or D. A ruptured myocardium. The correct answer is B. When the chest impacts the steering wheel following rapid forward deceleration, aortic injuries, shearing, or rupture are the cause of death in nearly 2/3 of patients. The aorta is the largest artery in the body. When it is sheared from its supporting structures or ruptures outright, exsanguination, bleeding to death, occurs usually within a matter of seconds. Answer A. A hemothorax. This is a serious injury, but it is not fatal in seconds. B is the correct answer. A pneumothorax, again, is a serious injury, but it isn't fatal within seconds. A ruptured myocardium is a serious injury, but it is not common. Review question 2. Signs and symptoms of a chest injury include all of the following except hemostasis, hemiomesis, asymmetrical chest movement, increased pain with breathing. The correct answer is B. Signs and symptoms of a chest injury include bruising to the chest, chest wall, instability, increased pain with breathing, asymmetrical chest movement if a pneumothorax is present, and hemostasis, coughing up blood if intrapulmonary bleeding is occurring. Hemomesis, vomiting blood, indicates bleeding in the gastrointestinal tract, usually the epiglottis or stomach, not the chest cavity. A. Hemostasis is coughing up blood or blood-tinged sputum. The correct answer is B, which is vomiting up blood. That is not a symptom of a chest injury. Asymmetrical chest movement. This may indicate a flail chest or pneumothorax. Increased pain with breathing. A chest injury will cause the presence of pain during insistory and expiratory chest wall movement. Review question 3. During your assessment of a patient who was stabbed, you see an open wound to the left anterior chest. Your most immediate action should be A. Position the patient on the affected side. B. Transport immediately. C. Assess the patient for a tension pneumothorax. D. Cover the wound with an occlusive dressing. The correct answer is D. If you encounter an open chest wound, you must cover it with an occlusive dressing. This prevents air from moving in and out of the wound. After the dressing is applied, you must monitor the patient's signs for a developing tension pneumothorax. A. This is not the most immediate action. B. Transport should take place once life threats have been managed. C. You must monitor for signs of a developing pneumothorax. D is the correct answer. Review question 4. When caring for a patient with signs of a pneumothorax, your most immediate concern should be A. Hypovolemia. B. Intrathoracic bleeding. C. Ventilatory inadequacy. D. Associated myocardial injury. The correct answer is C. A pneumothorax occurs when air enters the pleural space and progressively collapses the lung. This impairs the ability of the lung to move air in and out. As the lung collapses further, ventilatory efficiency decreases, resulting in hypovolemia. This should be your most immediate concern. Some patients with pneumothorax may also experience intrathoracic bleeding and associated myocardial injury, depending on the mechanism of injury and the force of trauma. Answer A. This may be indicated by the signs and symptoms of shock. Answer B. The patient may experience this, but inadequate ventilation is your immediate concern. Answer C is the correct answer. Answer D. The patient may experience this, but inadequate ventilation is your immediate concern. Review question 5. What purpose does a one-way flutter valve serve when used on a patient with an open pneumothorax? A. It prevents air escape from within the chest cavity. It allows the release of air trapped in the pleural space. It only prevents air from entering an open chest wound. It allows air to freely move in and out of the chest cavity. The correct answer is B. A one-way flutter valve is used to treat patients with an open pneumothorax and serves two purposes. It allows air trapped in the pleural space to escape during exhalation, and it prevents air from entering the pleural space on inhalation. These combined effects alleviate pressure on the affected lung, which allows it to re-expand. Answer A. It allows air to exit the chest. The correct answer is B. Answer C. It prevents air from entering and allows air to exit the chest. Answer D. It allows air to move out freely and prevents air from entering. Review question 6. Signs and symptoms of a cardiac tamponade include all of the following except A. Muffled heart tones. B. A weak rapid pulse. C. Collapsed jugular veins. D. Narrowing pulse pressure. The correct answer is C. A cardiac tamponade, which is almost always caused by penetrating chest trauma, occurs when blood accumulates in the pericardial sac. This impairs the heart's ability to contract and relax. As a result, the systolic blood pressure decreases and the diastolic blood pressure increases, narrowing the pulse pressure. Because the heart cannot adequately eject blood, blood backs up beyond the right atrium, resulting in jugular venous distension. In some cases, heart tones may be muffled or distant. Other signs include weak, rapid pulse, and hypotension. Answer A. This is an assessment finding of cardiac tamponade. The same goes for answer B. Answer C, collapsed jugular veins, is not a sign of cardiac tamponade. It's actually distended jugular veins. Answer D is also an assessment finding for cardiac tamponade. Review question 7. A patient experiences a severe compression to the chest when trapped between a vehicle and a brick wall. You should suspect traumatic asphyxiation due to the hemorrhage into the secula of the eyes. And what other signs? A. Flat neck veins. B. Cyanosis in the face and neck. C. Asymmetrical chest movement. D. Irregular heartbeat. The correct answer is B. The sudden increase in introthoracic pressure results in a characteristic appearance, including distended neck veins, a hemorrhage in the sclera of the eyes, signaling the bursting of the small blood vessels. Answer A. The neck veins should be distended. Flat neck veins may indicate a hemothorax. B is the correct answer. C. This is seen with a flail segment. D. This may be seen with a myocardial contusion. Review question 8. A 14-year-old baseball player was hit in the chest with a line drive. He is in cardiac arrest. Which of the following is the most likely explanation? A. Myocardial contusion. B. Traumatic asphyxia. C. Chondrocoritis. D. Hemothorax. The correct answer is C. Chondrocoritis is a blunt chest injury caused by a sudden direct blow to the chest that occurs only during the critical portion of a person's heartbeat. The result may be immediate cardiac arrest. The blunt force causes ventricular fibrillation that responds positively to defibrillation within 2 minutes of the injury. A. This may cause an irregular heartbeat, but rarely causes cardiac arrest. B. This is a result of crushing injury, not a direct hit. C is the correct answer. D. This comes from bleeding around the rib cage or from a lung or great vessel rather than a direct hit. Review question 9. Paradoxial chest movement is typically seen in patients with A. Flail chest. B. A pneumothorax. C. Isolated rib fractures. D. Ruptured diaphragm. The correct answer is A. Paradoxial chest movement occurs when an area of the chest wall bulges out during exhalation and collapses in during inhalation. This type of abnormal chest movement is seen in patients with a flail chest, a condition in which several adjacent ribs are fractured in more than one place, resulting in a free-floating segment of fractured ribs. A is the correct answer. B, this will produce unilateral chest wall movement. C, this will produce pain but not irregular chest wall movement. D, this typically occurs on the left side. You may hear bowel sounds over the lower chest area. Review question 10. A 40-year-old man who was the unrestrained driver of a car that hit a tree at a high rate of speed struck the steering wheel with his chest. He has a large bruise over his sternum and an irregular pulse rate of 120 beats per minute. You should be most concerned that he is A, has injured his myocardium. B, has collapsed lung and severe hypoxia. C, has extensive bleeding in the pericardial sac. D, is extremely high risk for ventricular fibrillation. The correct answer is A. A myocardial contusion or bruising of the heart muscle is usually the result of blunt trauma, specifically to the center of the chest. In some cases, the injury may be so severe that it renders the heart unable to maintain adequate cardiac output. As a result, blood pressure falls, the pulse rate is often irregular. However, lethal cardiac dysrhythmias such as ventricular tachycardia or ventricular fibrillation are uncommon. A is the correct answer. B, this will produce an absence or decrease of breath sounds and unilateral chest wall expansion. Answer C, this will produce a muffled heart sounds and decrease of cardiac output. Answer D, lethal dysrhythmias are uncommon. Okay, class, this concludes the lecture on Chapter 29, Chest Injuries. If you have any questions or concerns, please contact your instructor, and I will see you in the next chapter.